But I'm very happy to be here and to speak specifically about early feeding in the neonatal ICU. It's specific one of the areas where I love working. We as a practice work in 2 neonatal ICUs. And what's nice about it is the literature behind neonatal feeding is also forever changing. Yesterday I actually spoke to a colleague of mine who came off a flight from the European Neonatal Intensive Care Congress, and I'd like to share some points that she even mentioned. So in the last 24 hours, I've actually also learned more about this topic again. Okay, there you go. Just to start off with, the overview of my talk today is looking at the nutritional emergency that actually occurs when a premature baby is born. Secondly, looking at postnatal growth restriction as a phenomenon that happens after the birth of these babies. We're also going to be looking at the goal of nutrition support, the nutrient requirements of our preterm babies, nutrient delivery, some of the challenges we face in the neonatal ICU, and then also monitoring and, importantly, post-hospitalization of the neonatal ICU baby. The birth of a preterm infant is associated with major morbidity challenges, both in the developing and the developed countries. Now, recent advances in neonatal ICU has led to things like artificial surfactant, positive airway pressures, the use of also steroids in these babies, and this has led to a better mortality benefit. One of the biggest problems we're still seeing is the neurodevelopment mental outcome of these children, and this has been linked to inadequate nutrition support during this postnatal growth restriction period. The reason for this is that when an infant is born prematurely, obviously the umbilical cord was supplying it with a rich nutrient supply, and this is suddenly cut off. Corpelane et al. Feels this is a nutritional emergency that should be addressed immediately. However, the situation is not always that in the units. So, in reality, we do know that babies born prematurely usually have a low nutrient supply post-birth. The reasons for this is not clearly understood. In the literature previously, it was thought that feeding enterally or parenterally may be hazardous to the baby, where it can lead to acidosis or hyperammonemia. This has been shown not to be true. Also, they found that maybe growth restriction may be beneficial. Once again, this has been contradicted in the literature. Another important point to remember is in a preterm baby, we've got a very, very small reserve to work with. Usually, a 1 kilogram infant stores about 1% body fat and 8% protein, with a non-protein energy reserve of 110 kilocalories per kilogram. Under normal circumstances, this will lead to survival of 4 days, but we do know in the prevalence of things like sepsis and lung disease, the metabolic rate even goes up. Sorry. Just to go through the naming of the premature babies and the words we actually use in the NICU, just to remind you about it. A premature baby is any baby born before 37 weeks gestation. A baby with a low birth weight is born below 2.5 kilograms, very low birth weight below 1.5, and extremely low birth weight below 1 kilogram. A large for gestational age baby is a baby born above the 90th centile. Appropriate for gestational age between 10 and 90, and then small for gestational age below the 10th centile. So postnatal growth restriction is actually the phenomenon that we see after a premature baby is actually born. And this phenomenon leads us to see that the baby does not continue to grow the same as it would have as a fetus. So there's actually a very big change between how they grow intrauterine and how they grow extrauterine. The problem with this is there's many short and long-term consequences of undernutrition or postnatal growth restriction. The first is increased infectious diseases, specifically lung infection, lung injury, and then more need for mechanical ventilation. Furthermore, there's also a decreased maturation of the intestine, which is very problematic for us as dietitians. Lifelong physiological and metabolic effects are also present. Neurodevelopmental delay is usually seen in these children as the last trimester of pregnancy is actually very important for brain growth and development. We do know neuromyelinization takes place and that the brain actually increases twice in size, the cortical matter goes up, the grey cortical matter actually goes 4 times up in volume during this time. Interestingly enough, when premature babies are fed higher kilocalories and protein, especially in the population of boys, we do find that the neurodevelopmental outcome is a lot better at discharge time, and then again when measured at 18 to 22 months. The impaired feeding during early life can also have then these lifelong consequences, and this is where the adult onset disease theory comes from. It has been found that if an organism is actually starved during fetal or early life, that it can change and upregulate metabolism to the sense where it actually accumulates more fat mass, which in long term can lead to health diseases like diabetes, insulin resistance, cardiac problems, and so forth. So as stated before, postnatal growth restriction leads to poor developmental outcome, and this has been proven by multiple authors. A low intake of protein and energy during the first week leads to markedly impaired neurocognitive scores, and this is usually measured at 18 to 22 months, where they do look at things like fine and gross motor, as well as IQ and verbal communication, and that's done by means of Bailey scores. Once again, it seems the little boys do worse than the little girls in the ICU, and we're not sure why the reason is for this. It is also estimated that 1% of the endogenous body protein will be lost per day in the preterm infant if they only put on glucose. And starting parenteral nutrition on day 1 of life actually reduces the incidences of growth failure seen at 36 weeks. It must be emphasized that the association between growth failure and late cognitive outcome does not necessarily mean that growth failure is the cause of impaired cognitive developmental outcome. It seems what they have in comparison is an inadequate nutrition, and thus the nutritional emergencies that occur at birth with the preterm baby needs to be addressed quickly. So postnatal growth restriction is something that has been around for a very long time, but the authors actually found it quite hard to actually prove that there is this growth restriction. And Ehrenkrantz et al. Was important in showing the juxtaposition, which they call it, on the following graph, where they actually looked at the intrauterine growth between a fetus and that of a premature baby. What they found was that most babies drop between 1 standard and 2 standard deviations weight for age prior to their discharge, and they do not grow as the fetus does. The reason for this is multifactorial. We do know in some cases we have delayed nutritional therapy, also inadequate nutrition due to volume restrictions, enteral feeding intolerance. Also, to actually start the babies on enteral nutrition many times is problematic due to an immature gut, and working from there to actually get to full feeds are also hard because we have a volume restricted approach depending on the gastrointestinal tolerance. It's also been found that in some neonatal ICU units, it seems that some of the babies are fed high energy levels in the presence of low protein. And some authors have actually mentioned that a lot of babies on discharge are quite short for gestational age, with a low lean body mass and a higher visceral fat mass, which of course also predisposes them to things like diabetes and insulin resistance. So it's very important that we look at the recommendations and actually achieving the recommendations in this patient population. The goal of nutritional therapy is then definitely to get the similar growth that we get in a fetus. However, this seems also to be quite a challenge. Fetal growth rate in the last half of pregnancy is around 15 grams per kilogram per day. And towards term, we're looking at 10 grams per kilogram per day. They replace their water stores of about 90% at 24 weeks with protein and fat. And at term, usually a baby has about 70 75% fluid. So the lipid and protein content goes from about 2 and 8.8% respectively, all the way up to 11% lipids and 12% proteins. And the preterm infant goal rate, which we've been currently working on, of 15 grams per kilogram per day, is often not achieved. Now, once again, it's because these babies are in an extrauterine environment, they're prone to infection, they're not necessarily getting the nutrition they need. What's also quite interesting from this neonatal congress where my colleague was they reported back that this 15 grams per kilogram per day is actually too low a aim for us. It's actually seen as suboptimal. So in future, we might see some literature coming out that we should be aiming for higher rates of growth per day in this patient population. So how do we actually assess what the nutrient requirements are of our neonatal ICU babies? There are two approaches. This first is called the factorial method, where they actually looked at the accretion of nutrients by the fetus inside the womb, and they tried to base nutritional requirements on this. The second approach is called the empirical approach, where they actually look at limiting growth enhancing nutrients like protein and energy, and seeing how a preterm infant actually grows on these. This table, which was in the Annales of Nutritional Metabolism in 2011, gives us an idea, when visited closely, I don't know how much of it you can see at the back, that we're aiming to an energy reserve of about 90 to 131 kilocalories per kilogram per day, and protein definitely between 3.5 and 4 grams per kilogram per day. The last recommendations we had available for enteral nutrition in the premature babies is those from Espegan. And what's interesting to note is that we're looking at 110 to 135 kilocalories per kilogram per day. And in the babies under 1, 4 to 4.5 grams per kilogram per day. Between 1 and 1.8 kilograms, we're looking at 3.5 to 4. Now, a Scandinavian author actually responded back at this neonatal congress where they actually did a multi-centered trial. I don't have any slides on it because, as I said, it just actually happened and my colleague just informed me about it. But they were looking at the higher levels of protein, 4 to 4.5 grams per kilogram per day. And they were actually stating that in their patient population, they did see that this leads to increased rates of late onset sepsis, increased rates of infection, and then importantly, they didn't see a growth benefit. Now, we struggle in the neonatal ICU to get to 4 and 4.5 grams per kilogram per day. And I would just tread on the side of caution when working with babies under 1.2 kilograms to just be cautionary when you're actually pushing the protein very high to these levels. What's nice about the Espegan recommendations is they further break down the micronutrient and vitamin recommendations for the babies as well. And we find this very helpful when working with certain patients where we actually need to supplement vitamin D, certain syndromes where we have to make use of additional calcium or phosphate, just to make sure that we're still within the parameters. When it comes to parenteral nutrition requirements, I found this update from Valapi in 2011, which they actually looked into, once again, the energy recommendations for PN as well as the protein. And importantly, Valapi put a lot of evidence into the sodium, potassium, calcium, and phosphate levels that we need to achieve in our babies. We do know these babies have an increased incidence of bone diseases later on in life, and that the electrolyte levels also seem to change from day to day. Valapi looks at energy at about 110 to 120 kilocalories per kilogram per day, and then protein ranging between 1.5 up to 4 grams per kilogram per day. The last ESPN and Espegan guidelines for parenteral nutrition are quite similar. Where they do differ is they actually give us a higher lipid and carbohydrate requirement. When you look back on the Valapi requirements, he recommends 6 to 8 grams per milligram per minute per kilogram for glucose, whereas in the case of the Espegan and ESPN guidelines, it's up to 8 to 12.5. VELOP does, however, recommend that if we can control the blood glucose of the babies between 2.5 and 8.3 millimoles per liter, that we can incrementally increase the glucose oxidation rate. For us as dietitians, the most important factor to remember when calculating glucose, lipids, and then energy is that there are non-nutritive sources of energy going into these babies. And that's where we need to be specific in looking at the IV fluids, whether they are being sedated with propofol or diprovan, whether medications like Polygam are used. I recently had a child on Polygam. When I looked at the mixing, it takes 5 grams of sucrose per treatment dosage of Polygam, and that can obviously throw out your nutritional requirements quite a bit. So parenteral nutrition delivery usually happens within a very short period after birth. Ideally, we would want to start enteral nutrition, but due to the immature gut of the baby, we're sometimes not able to start immediately, and we rely on parenteral nutrition to actually give us the patient's recommendations. Protein can be started within the first 4 hours of life, sometimes even sooner, and lipid on day 1. What's important to note is that trophic feed should be started as soon as possible. The literature recommends day 1 to 2 and slowly and incrementally increased due to the tolerance of the baby. Now, parenteral nutrition has had a very bad rap in the past when it comes to premature infants, but even though it does cause line infections in some cases and is very costly, it still leads to a mortality benefit in this patient population. It leads to anabolism, upregulation of the antioxidant system, and then also causes less neurological damage. Once again, the studies were shown specifically in the boys' population. Parenteral nutrition for neonates is then not just a replica of adult parenteral nutrition. It actually contains different amino acids and some conditionally essential amino acids like taurine, cysteine, and so forth. And with the new upcoming lipid formulations that are almost available in South Africa, there has been a lot of evidence to show less liver toxicity, less peroxidation due to the vitamin E content of the bags, and then also immunomodulatory effect. At birth, the gastrointestinal tract of the infant is highly permeable and prone to necrotizing enterocolitis. It's both immature morphologically and physiologically, as well as functionally, and thus gastrointestinal aspirates may differ in terms of size, they may be bile-stained, and they may actually be large as well. Thankfully, the gastrointestinal tract of the preterm infant can actually undergo maturation. It is said if trophic feeding is started with breast milk within the first day to 2 days of life, it can actually be, the gastrointestinal tract can actually be matured within 2 weeks. Parenteral nutrition is usually stopped at the point where full feeds or more than 90% of energy requirements and protein requirements are met via enteral nutrition. I'm sure, as you all know, the American Academy of Pediatrics, the WHO, as well as the United Nations Children's Fund do recommend breastfeeding to term babies for the first 6 months of life. However, in the preterm infants, it is less well defined. We do know that breast milk is the substance that leads to the maturation of the gut the quickest, and that it actually is a great cost saver in the NICU. However, all mothers do not easily find expressing breast milk, and they have a whole range of their own problems when it comes to breastfeeding. In the US, even though 69% of term infants and mothers initiate either partial or exclusive breastfeeding, the average rate of breastfeeding at discharge is usually around 50%, and that's for term infants. With preterm infants, we do know it's even lower, especially in the group of patients below 1.5 kilograms. So as we all know, the composition of breast milk does change. It's not a discrete entity, but one that varies with time after delivery, length of gestation, length of each lactation session, method of expression and collection. When it comes to term versus preterm milk, we do know that preterm transitional milk have higher levels of protein, zinc, sodium, calcium, copper and folate than breast milk. What's also interesting is the method of expression is actually also changing what we're seeing in terms of the breast milk, with hand expression leading to higher sodium levels in babies. We still differentiate with preterm babies between fore milk, hind milk, and then also drip milk. Fore milk being the milk that is produced in the first 2 to 3 minutes, that actually just is mostly fluids just to prevent dehydration. It's lower in energy and in fat. Hind milk is the milk that contains most of the energy, and then drip milk is the milk that comes from the other breast whilst expression happens. And in the 1980s, this was actually thought to be a great source of breast milk as a donor milk for other preterm babies. But the growth outcomes of these babies were really bad until the milk was actually studied and seen that it is similar in composition to fore milk. Okay. Sorry, I just want to move on. So the benefits of breast milk for trophic feeding is then specifically that it reduces intestinal permeability, it stimulates cell proliferation, enhances gastric emptying, and then also facilitates early achievement of full enteral feedings. Long-term benefits, on the other hand, include better neurodevelopmental outcomes. It also has a protective effect in terms of atopy or allergy in the high-risk individuals up to the age of 4. There's also a decreased incidence in the severity of retinopathy of prematurity compared to when formula is actually used. And there's definitely a psychological benefit to the mother. The ability for the mother to provide breast milk to this critically ill little child who she can do nothing else for has been actually shown to gather strong feelings for the babies and give them maternal empowerment, and then also increase their self-confidence and self-esteem. One of the long-term effects of using breast milk as feed of choice for preterm infants is then also a lower diastolic blood pressure and mean blood pressure at adolescence due to the high DHA content of breast milk. Donor breast milk is often used when maternal milk is not available, especially in the first few days of life. And according to Quickly, it exerts similar effects to breast milk on the immature gastrointestinal tract. What is important is to know that because it's pasteurized, it still has lower levels of lipase, lymphocytes, and some other important components. But in our unit, it's definitely something we do use when there is no breast milk available. The use of breast milk fortifiers are recommended by Espegan 2010. They do say that breast milk is the ideal formula for a preterm baby. However, it should be supplemented, seeing as breast milk by itself actually leads to poor growth rates and nutritional deficits during hospitalization. Specific nutrient deficiencies of preterm breast milk can be corrected through the appropriate supplementation. A Cochrane systematic review of breast milk protein supplementation with approximately 1.5 grams per kilogram per day evaluated a total of 90 very low birth weight infants in 4 randomized controlled trials. What they found was the infants who were supplemented grew better by 3.6 grams per kilogram per day in terms of weight gain, 0.18 centimeters per week in terms of length gain, and 0.15 centimeters per week in terms of head circumference. Breast milk fortifiers should be initiated at around 100 ml per kilogram per day. However, in some units, they do start them earlier. It may, however, increase gastric residual volumes if started earlier. Breast milk fortifier contains both protein and energy substrates as well as vitamins, minerals, which are important, and on average increase the protein content of breast milk to 0.8 grams per 100 ml. Breast milk alone leads to slow growth of premature infants, and thus we should rely on the fortifiers where possible. It is important to remember that once you are using a fortifier, you are no longer doing exclusive breastfeeding and you are actually diluting some of the other components of breast milk as well. Another concept that can be used in the neonatal ICU for infants who still struggle to gain weight on breast milk plus fortifiers is what we call adjustable fortification. This is where additional polymers and modular powders can be used to actually increase the protein and calorie content of the milk. It is important to note that the efficacy and safety has not been studied, and whenever fortifying on top of breast milk, one should always work out the osmolarity of the feed and make sure that you're not actually supplying hyperosmolar feed, which can lead to many problems. Preterm formulas are great to use if breast milk is not available and donor milk is also not available. In essence, they're higher in energy and protein and in some of the electrolytes as well. Typically looking at 80 to 82 kilocalories per 100 ml. Just something on prebiotics and probiotics, because this can be a whole talk by itself. We do know that breast milk contains 130 different oligosaccharides that are fermented in the colon, and they exert a lot of positive effects on the premature baby, specifically when looking at maturity of the gut, removing bowel, forming softer stool, and so on. This has been replicated by Gosfos in a lot of the preterm formulas. However, when the Espegan recommendations came out, there was not a lot of evidence for this yet. Since then, it's been shown that Gosfos can increase fecal bifidobacteria counts, reduce the stool pH, and then also accelerate gastrointestinal transport, which is important. Probiotics, on the other hand, are also found in breast milk. What makes sense in the neonatal ICU population is many of these babies are actually born via cesarean section, so they do not pass through the vaginal tract and they do not get colonized by their mothers. In many cases, they also have delayed enteral nutrition or breast milk, and they don't have skin-to-skin contact, so they are many times actually colonized by the NICU environment. However, when looking at the literature, at the last Espegan recommendations, there was nothing available. Since then, a few studies have come out in the neonatal ICU environment. One such a study in the BMC Pediatrics 2012 showed that statistically significant benefit is seen in prevention of NEC when using Alreuteri DSM 17938. Mohan et al. Also did a study where they showed in the NICU environment, by supplementing beta-lactus BB12, the bifidobacteria levels are increased significantly, and the other enteric bacteria, which may be negative, are reduced. For us as dietitians and healthcare professionals, what's important to note with the use of probiotics is that we should know exactly what genus, what species, and what strain was used in the literature. We also need to know the dosages, we need to know the studies before embarking on using these products. Espegan does put out a safety recommendation that it is still an antimicrobial product that we're using, and we should consider the risks of using this. Just regarding some of the challenges faced in the neonatal ICU, there are many to mention, and one can go into a lot of detail on each one of these. What's important to note is that we cannot work in solo in the neonatal ICU. We have to work as a multidisciplinary team. And when dealing with things like central venous line-related infections, deficiencies or excess of PEN components, liver abnormalities, metabolic bone disease and growth impairment, NEC, hyperbilirubinemia, fluid restriction, catabolism, and gastroesophageal reflux, we should actually work as a team and discuss it between us and the doctors and the nursing staff to actually come up with a solution. For example, with gastroesophageal reflux in the neonatal ICU, If it is to the extent where the baby is not growing, where there's blood in the emesis, where they're fussing and crying after every feed, and where we're actually not getting further with the baby, where there's also some respiratory issues, it is something that can be addressed pharmacologically and surgically if needed. And also we can discuss as dietitians with the doctors the effect of certain medication on the lower esophageal sphincter pressure. For example, theophylline and caffeine is used a lot in our neonatal ICU due to our high cardiac load of patients. And these are medications that can lead to reflux. For us as dietitians, the only evidence that is out there is actually to reduce the feed sizes and offer more frequent feeds and then help the baby from there. There's also some evidence looking at underlying allergy and treating the allergy in this population of patients. In an ideal world, dietary needs of preterm infants are addressed in detail on a daily basis, taking into account changes in their nutritional and clinical status. And monitoring should entail a full nutritional status assessment, looking at the clinical, biochemistry, dietary, and then also anthropometric side of things, and then working on a treatment plan with your doctor to actually restrict the poor growth we see in the babies. There are a lot of guidelines out there on how we should monitor parental nutrition. I'm just going to skip through this one and go to this one done by Valapi, looking at how often we should monitor glucose, serum electrolytes and urea, calcium, magnesium and phosphorus at least once a week, liver function weekly, urine glucose same as glucose, usually 6 to 8 hourly, and then weight, length and head circumference ideally weekly. In the unit we work, we actually make use of the Fenton growth charts as a way of looking at the anthropometric assessment. And it is good to still use growth charts because we do not know whether that 15 grams per kilogram per day we were aiming for is sufficient. And very importantly, the babies are different. Each baby is individual, and that's why the growth charts are so crucial to make sure, are we actually reaching requirements or not? Under dietary assessment, I always just feel it's very important to remember the mother as well. Yes, we look at reaching the goals of the baby and whether they're drinking enough, and we check their aspirates and everything else, but many times the mothers are actually neglected when it comes to nutrition due to the stress-induced environment they're in. They do not eat well, and in many cases by just discussing with them some supplementation ideas or even speaking to their gynecologist about getting a medication to increase their milk supply, you can actually support them in a great way as well. One of the areas of neonatal ICU feeding, which I think is sometimes neglected, and definitely in the literature we do not find a lot of evidence for it, is the post-hospitalization period. Espegan does mention that it's important to measure the length, head circumference, and weight at regular intervals. Post-discharge, this is usually done once a week, thereafter once twice weekly, thereafter monthly, and then 3 monthly in these babies. And infants with appropriate post-conceptional age at discharge can be fed breast milk or term formula. The group where we actually get worried is those with a subnormal weight at discharge for their conceptional age. And these babies need to be continued on supplemental breast milk or then a post-discharge formula. And ideally, this should continue up until 40 weeks of age or even 52 weeks of age. And this should be monitored by a dietitian to ensure that the supplementation is still correct and that we're not causing hyperosmolar problems. This is just a table from Espegan showing the difference between a standard formula, a post-discharge formula, and a preterm formula. In most of the cases, a post-discharge formula might be sufficient to still have these babies with a suboptimal weight, gaining weight correctly according to their charts. But there are the odd babies where we actually have to stick to a term formula to ensure that they're gaining weight, or then make use of adjustable fortification plus breast milk fortifiers on top of breast milk. I just wanted to mention here as well that the neonatal ICU population of patients do sometimes experience later on problems when it comes to weaning and toddler feeding. And in these cases, it may be due to problems with sensory integration, oral tolerance, etc., from being hospitalized for a very, very long period of time, and also because a lot of them exhibit neurodevelopmental delay. And for us as dietitians to treat those patients as a solo entity is really, really hard, because you can work out all the calories, work out a diet plan and everything, but these babies might not gain weight. And what we find very helpful is to actually work with a speech therapist that's neurodevelopmentally trained, as well as occupational therapist, where we actually as a team make sure that these children continue to actually grow and develop normally. I'd like to end off with just 2 studies which I found quite interesting, looking at why a dietitian is actually needed in the neonatal ICU environment. The one was done by Oslin in 2005, where 417 neonatal ICU units were contacted and questionnaires were actually filled out by the head of the units. 3 categories were set up, whether they have a dietitian, whether they have a consultant dietitian, or a full-time dietitian. And what they found was the neonatal ICUs with full or part-time dietitians provided fewer kilocalories and protein in the form of parenteral nutrition and more in the form of enteral nutrition, which is very beneficial, of course. Furthermore, the units with less dietitian involvement were more likely to provide full-term formulas and unfortified breast milk than those where the dietitians were involved. They also allocated a nutritional score, and where there was a full-time or a part-time dietitian, the nutritional score was 5.6 versus 4.6 to 4.7 in the units where there was no dietitian. They concluded to say that the reasons that some of the units do not have dietitians is lack of funding, lack of trained dietitians, and lack of perceived need. But they concluded that more involvement of registered dietitians in the neonatal ICU increases the intensity of important aspects of nutrition care, and thus improves the outcome of the very low birth weight infants in the neonatal ICU. A similar study by Sneeve was done where they looked at a period prior to having a multidisciplinary team that had a dietitian, and then actually getting a team involved with a dietitian, and how this changes the outcomes, especially anthropometrically, for the neonatal ICU. They found that the mean weight at the beginning of enteral feeding was significantly less in the period prior to having a dietitian. The weight at discharge, the total weight gain, total daily weight gained from birth to initiation of enteral feeding, daily weight gain from birth to full feeds, and head circumference growth was significantly greater for neonates in the post group than it was in the pre-group. And implementation of a multidisciplinary team that included the dietitian improved the outcomes in the low birth weight patients in neonatal ICU. So we as dietitians need to facilitate timely nutrition interventions to minimize the effect of postnatal growth restriction as part of a multidisciplinary team. Other than all the benefits already mentioned, we do know these babies can have a shortened hospital length of stay and a reduced related cost when a dietitian is involved. Thank you very much.